Hello, everyone, and welcome. Thank you so much for joining us for today's call. This is the End-Stage Renal Disease Network Learning and Action Network series, with today's call focusing on home modality, quality improvement activity. Thank you so much once again for joining us. And here on screen, you can see just a couple of reminders regarding today's session. We are currently streaming the audio over computer speakers to help free up telephone lines at your facility. But just know that if you need a dial-in number, please feel free to send us a message via the chat window. We'll be more than happy to assist you with ensuring that you are able to not just see the slides as we go on today, but you're able to hear the presentation as well. If you are currently hearing an echo, echoes are caused due to multiple connections to the same computer for the same event, so close all but one, and that should help with resolving the echoes that you might hear. Also, since you can hear from us, but we cannot hear from you verbally as part of today's session, we do encourage that you get involved, and you can do so by sending us chat questions and comments by using the chat feature that's located on the left-hand side of your screen. With that, I'm going to pause for a moment and turn the call over to Stephanie Hull, who will serve as our host for today's QIA LAN. Stephanie?
Yes, hi. Thank you, O'Neill, and welcome everybody, and good afternoon or good morning, depending on where you're all at. Again, I just want to reiterate, thank you for taking time out of your busy day today to join us for our very first home QIA LAN for 2019. With today, we have a speaker, and his team will be joining us momentarily. And as we go through the slides today and the presentation, I would like for everybody to think about some best practices that they can take away from today's LAN call. I'd like you to be, while you're listening, you can also share any approaches or experiences that you've had via the chat, and also identify how some of the shared information could be used at your facility during the day, here today, and be able to apply at least one idea from today's LAN at your facility. So, why are we having these LANs, and why is it important that everybody attends? I think we all know that home dialysis is a better choice overall than in-center, but what is it about home that makes it better for the patients? Well, a couple things. I think the survival rate is 58% for a 5-year survival rate for patients who are on more frequent home dialysis than patients that are on conventional dialysis. Their survival rate is 40%. So that's a very good reason why patients should be referred to home. Another reason is, despite the rise in home dialysis, it's still only being used 3.1% of all incident ESRD patients receiving dialysis in 2016. So it's still very underutilized. It's still an option that we really want people to think about today as Dr. Daoui and his team does the presentation and there's time for questions and answers. I think we really need to think about patients out there who could be possibly and potentially candidates for home hemo. And I really want you to think about today is, what can we commit to do today? What one thing can you identify and take away from the call today that you can implement in your facility that will directly increase the number of patients choosing home dialysis? Think about that throughout the call. Really be thinking about how that can help, one thing that can help impact your facility to increase the referrals to home. Many of you had done the pre-work questions that we sent out last week, and I'd like to share the results with you today. There were 2 questions that we sent out. One was, does your facility have guidance about which patients would do well for home dialysis? We've got 449 respondents, and of those, 78.8% said yes, they do have guidance, and 21.6% said no. The second question, can patients use home dialysis without a care partner being present during the treatment? Now, this was very interesting. It was a very split decision, almost exactly half and half. 50.56 said yes, the patients can do their home treatment without a partner, and 49.44 said no, they cannot do a home dialysis treatment without a partner. So I'm kind of hoping today Dr. Daoui might share some ideas and practices and some insight on that particular question. So I will go ahead and introduce our speaker. Dr. Daoui is board certified in nephrology and internal medicine. He is the chief of the nephrology division at Saratoga Hospital in Saratoga, New York. He is also the home dialysis program director for the Rubin Center Dialysis, which has the largest next stage program in the country. He has played a key role in clinical trials that led to the Food and Drug Administration's approval of the nation's first and only hemodialysis device for use at home overnight. In addition, Dr. Daoui was one of the principal investigators of a landmark study, the Freedom Study, from 2006 to 2009, published by the International Society of Nephrology in 2012, which demonstrated the health benefits of at-home, short, frequent dialysis. Whenever possible, Dr. Daoui encourages patients to choose home dialysis because it best mimics the function of our kidney. Our kidneys work every second, not just 3 times a week, he says. 25% of his patients rely on home hemodialysis, compared with 1.8% of the patients nationwide. So I'm going to turn over the call to Dr. Daoui.
Thank you, Stephanie. So before I start, I would like to thank all of you for signing in, and I'm really excited to share with you this presentation. And currently, I am with the home team, the home team that helped me, that helped the Rubin Center and the DCI shine in the world of hemodialysis are with me. And also, I invited one of my patients. So we are really excited. So the talk today, the goal for talking about home hemodialysis is, number one, I hope that at the end of the talk you are going to understand why home hemodialysis is important, and also I'm going to review with you our experience in providing home hemodialysis since 1998, and how can any one of you or any center, any renal center can use the tool that or the experience that we acquire and can use it in starting a new program or improving the existing program. So in the last few slides, I just printed the certain key points that I will show you that may help you maybe think about maybe doing things differently. So when I don't have any conflict of interest, no financial tie to next stage. We gave a lot of talk about next stage things, but we have no financial tie with them. And so my home team present with me, I will introduce them briefly. So the first, Dr. Amy Hogan, I've been working with her since 2003. She's the program director of the Rubin Center in Clifton Park and the home program director. Sherry Maiola, she's the one who started the home program under the Rubin Center in 1998, and she's here. Christine Lansing, she's also the home program coordinator, and she was with Sherry Maiola when they started the program in upstate New York. I joined them in 2003. And Pasqualina Mayer, she's the technical manager. So anything that has any technical aspect of a home hemo will go to her, and she will solve our, she will find the solution. Donna Vargo, she's the home hemodialysis trainer. She has been with us for the last 16 years. So when I see patients in the clinic, when they are chronic disease stage 3, when they are stage 4, stage 5, and we start talking about the option of end-stage renal disease, many of my patients, I share with them this slide. So many people, they don't feel comfortable discussing about this, but I think it's important, and you'll be surprised when you tell them about the certain data. You'll be surprised how they change their mind and they do things that you want to advocate for. So the first slide it will tell you about the mortality rate in the end-stage renal disease patient doing in-center. The first year, 22%, second year, 34%, 3 years, 43%, 5 years, 58%. So the patient, they need to know that before they make choice. And so the lifespan of patient between 40 to 45, the life on end-stage renal disease in-center is only 11 years versus 35 years. Between 60 to 64, lifespan is 56 to lifespan is 5 to 6 years versus 20 years. So I think that's one of the tools that you can help you recruit patient. The patient need to know. So the 41% of deaths were cardiovascular related, with nearly identical percentage in hemodialysis and peritoneal dialysis patients. In this slide, it will tell you about the projected growth of the end-stage renal disease population. So in 2013, we had 468,000 end-stage renal disease patients. In 2025, we are going to have 649,000 end-stage renal disease patients. The growth is 36% between 2013 to 2025. So if then in 2025, 650,000 patients. So that means that if we follow the same pattern, let's say 85 to 88% of these patients are doing in-center, we need to build more than 3,000 new renal center. And as you know, there is a shortage of nephrologists and shortage of renal nurse. This is the 5-year survival rate of end-stage renal disease patient. So 40% if you are doing in-center, 50% if you are doing PD, 58% if you are doing home hemodialysis. So I asked, these are the 58% these data are from Next Stage. So I was curious. I asked Next Stage, I told them, could you please get me our own data with the Ribbon Center from 2010 until 2014, where at the end of 2014 we were acquired by DCI. So I'm going to show you the data, because my thinking, if you have more experience and if you're providing more home hemodialysis, the numbers should improve. And you will, in the following slide, I will show you our own data compared to the 58% 5-year survival rate in home hemo patients. If you want to do home hemodialysis, you can do different things. Nothing is set in stone. So you can do 3 times a week, like you are doing in-center, but you do it at home. You can do more frequent one. You can do every other day, which will give you like 3.5 day. You can do 4 days, 5 days, 6 days, 7 days a week. You can do short treatment from 2 hours to 4 hours. You can do longer. You can do it at night. We call it nocturnal hemodialysis. You can do it up to 6 hours. And the nocturnal, you can do it 3 times, 4 times, 5 times. It depends of the lifestyle of the patient, and it depends of how the patient feels. So you can do a lot of things when you are in control and you try to fit your own life and your family life. So in 2005, the Next Stage was approved, and that time we had like 1,700 patients on home hemodialysis. The first patient who used it in New York State was one of our patients in Clifton Park. That was in 2005. Then, if you can see, in 2015, we are 8,000. We have 8,000 patients. That since the Next Stage was approved, and so that's. So now I want to just tell you a little bit about the Ribbon Center, because it's important for you to know, because we acquired many things from the experience that we had, and I left like I told you at the end of the slide, I will tell you what you can do on your side based on the experience that we had. So the Ribbon Center was a small unit for non-profit organization. We had 3 centers. We were providing home hemo in Saratoga and Clifton Park. So, and the center started in 1998. We were using Fresenius machine from 1998 until 2005. 2005, we started using Next Stage system. So from 2005 until 2014, we provided more than 100,000 treatment, including the training. 100 treatment of home hemodialysis. So this is the census that we had with the ribbon. So we had the total of 300 patients in the 3 centers, all in the in-center and the home. Among the 300, we had almost 90 patients were doing next stage. So we were training in Clifton Park and Saratoga, and you can see the census. So for example, in 2011, you can see on the green line, the green bar, this is the number that we had, and on the purple one is the number that we trained that year. So if you follow the purple bar, you will see the number that we are training, like in 2009, 20 patients, 2010, 35 patients, in 2011, almost 35 patients. So we were training every year. We were very aggressive in training a lot of patients. And if you can see the mortality rate each year, you can see on the blue one, that's the mortality rate. So the first, in 2009, it was only 6, 7, and you can see 2014, it was about the same. So we were training a lot of patients, and the mortality rate was low. So this is our own data. Remember the home hemodialysis, the 5-year survival rate. It's 58 patients for home hemo patient. Our own data for Ruben from 2010 until 2014, following the patient 2015. If you can go to the 5 years mark, the death rate was 14%, 14.2%. So our 5-year survival rate was really high. It was around maybe 80 something, 86%. So if you are providing more treatment, you have more experience, you will do more than the 58%. So this is a slide to tell you about the growth potential of self-care. This survey that was done, 600 renal professionals, 6,000. They asked them about what they think about self-care in end-stage renal disease patient, and they thought that maybe 30% of the patient will be they can do self-care, home hemodialysis. So when you ask physician, nephrologist, 240 nephrologists in the US, they will tell you maybe 50% of our patients can do self-care. If you ask the patient themselves, they will tell you that at least 40% of them, they can do self-care, but they choose not to. So the conclusion of this slide, so that at least 40% of these patients can do self-care with the right environment and with the proper training. And so this is what we use in our center. Before we were using Fresenius machine. Now we are just using next stage. So it's a 75-pound machine. This is PureFlow. You can use a bag. It was approved for short daily initially. Then 2014, December, it was approved for nocturnal. And my team was part of the study that showed the safety for nocturnal application. You don't need a lot of modification at home. Really, not a lot of modification. You can travel with this machine, and so remember when I see patients in the clinic, before they start hemo, I will tell them about the mortality rate and I will tell them about a lot of things. But once the patient are in center, your approach will be different if you want to recruit patients. Once they are in center, they will be asking. They want you to tell them something that helps them with symptoms. And this is study that in this slide they ask 550 hemo patients doing in center, and they told them about what are the most common symptoms that you have. And so they will tell you that 80% of those patients they had cramping, they had fatigue, hypotension, cramp, headache, dizziness. So they have a lot of symptoms. So, the conclusion of this study, the conclusion is that once the patients are symptomatic, relieving the symptom, it's more important than life expectancy. So you need to tell them, listen, there is data, and that I'm going to show you, that your life is going to improve, your symptoms are going to improve if you change modality. And so remember, the approach will be different. So there is a nice nice publication, nice papers that were written, and they were published in American Journal of Kidney Disease in 2016. It will tell you about the benefits of home hemodialysis. So if you want to promote the modality, you have to understand why it's beneficial, and you have to be able to explain it to the patient and to their family member or even to physician. So on this slide, there is study that compare the benefits of home hemodialysis, short daily, and nocturnal, and 3 times a week in center. So if you can see in this slide, if you do nocturnal, you can reduce the intradialytic hypotension by 67% nocturnal. For short daily, 21%. So and these are grade 3. Grade 3 hypotension is that when the patient is very symptomatic, you give them normal saline and you stop removing any fluid. So that's grade 3. So that one. So you can use this slide to discuss with your patient and tell them that you're going to improve their symptom if they change modality. So this is the next slide will tell you about the benefit on blood pressure. So this is a summary of 41 study, and the mean blood pressure was reduced by 9 to 14%, systolic blood pressure 4 to 16%, diastolic blood pressure 4 to 12%. From 20 to 25% of patients completely discontinued the use of antihypertensive drug. Almost all other patients decreased the number of pill and or type of antihypertensive medication needed. This is very important point, recovery time. I will tell you more about recovery time. So this study that was done showed that the recovery time in 3 times a week, it will take you 7 hours to recover from one treatment. Daily hemodialysis, 0.6 hours, nocturnal, 0.2 hours. There is also data showing that home hemodialysis patients, when they go to the hospital, you can see a reduction in hospital day per year from the expected 14 to 8.3 compared to patients who are doing 3 times a week. So there is a study that we did called Freedom Study. It's a landmark study that showed the benefits of more frequent hemodialysis, and it was published in Kidney International. So what we did, we took 500 next stage patients all over the country, compared them to 5,000 end-stage renal disease patients doing 3 times a week, and we looked at the non-dialysis cost of care, quality of life indicator, the restless leg syndrome, the depression, and other parameters that I will share with you. So if you can see, the first thing that we notice, recovery time. So recovery time, after 4 months of home hemodialysis, recovery time will take you 1 hour. In center, 3 times a week, between 7 to 8 hours. So that means it may result in a day of quality time back to patient each week. So if you have patient going to the center doing 3 times a week, look what happened. They travel to center 1 hour, preparation 0.25, treatment 4 hours, wrap-up time 0.25, travel from center 1 hour, recovery time, remember recovery time in center, 7.7. Then one treatment will give you 14 hours. You multiply by 3, it's 43 hours. If you do short daily, 6 days a week, there is no travel time. You have treatment for 3 hours, and you do 6 days a week, take in consideration recovery time 1 hour, it will give you total of 29 hours a week, even though you do 6 days a week. So there is also benefit in depression. So as you know, there is a link between depression and mortality rates, and for the prevalence of depression and stage renal disease patient is very high. So on this study, on the landmark study, we found that there is statistically significant reduction in depressive symptoms. We use a score called BDI score, and after 4 months of home hemodialysis, we saw significant improvement in depression. There is also statistically significant improvement in physical and mental functioning of those patients, and there is a score that we use called the SF36 score. There is also, we published another study that was extrapolated from the Freedom study that we did, and we published this in the Clinical Journal of American Society of Nephrology, showing the benefit of in controlling the restless leg syndrome and sleep pattern. So that's for the transplant. The people who are next stage, they are the one who will have more transplant compared to patient doing doing in center, doing PD, and these are doing in center. The survival rate post-transplant is much better if you are doing next stage. So who is a good candidate for home hemodialysis? So number one, patients who are tolerating in-center hemodialysis poorly with hypotension, cramp, prolonged post-dialysis symptom, depression, restless leg syndrome, sleep disturbance, CHF, low ejection fraction, patients who are feeling PD, patients who are feeling transplant, patients who have to travel long distance with dialysis, patients who want to work, study, and care for family. At the end of the slide, there is no medical comorbidity that preclude being trained for home hemo, except if the patient really demented and if he has no partner. So.
Oh, okay. Dr. Daoui, we're going to jump in here, and we're just going to take a moment to do a polling question for all the participants. We have a question. Can you think of a patient at your facility that might be a good choice to use home hemodialysis? So I'm going to just, there's questions coming, the answers are starting to come into the question, so we're just going to give everybody just a little bit of time to respond and then share the results. So we're hoping as we go through this that you're thinking of patients at your facility that can be a good home hemo candidate. So I'm just going to, they're starting to slow down, so I will close the poll here. Okay, so we did get a total of 685 participants that responded to our question, and overwhelmingly we had 599 said yes, they can think of a patient that would be a good home hemodialysis patient, and only 86 said no. So that's those are very good to see that. All right, Dr. Daoui, you can continue on.
So Stephanie, you saw that I'm able to, we are able to convince your audience that they can do more.
Right.
So the next few slides quickly, that's the experience that we are required, and I will tell you certain points that it will be very useful for you to have a good program or improve your existing program. What makes our program successful? Number one, dedicated staff willing to bend over and backward to help this patient and think outside the box to troubleshoot and make it work. Number two, accepting challenge that not everyone is 100% able to do everything and finding way to work around it. The trainer are willing to train the patient at time of day that work for patient to accommodate their life. Sometimes we train them late of the day. Sometimes we did a few times on the weekend. Give it a try and go for it, and never turn the patient away. You need to have an open dialogue relationship with your nephrologist. I get a lot of calls from my home team about changing medication, especially when we start patient, and so I communicate with them. Myself and Dr. Amy Hogan, my partner, we communicate with our team on a regular basis. So we talk and breathe home hemodialysis, and we love it. So we need to have this kind of relation with the nephrologist. There is a program called Experience the Difference. So we take patients from the center, inpatient, and if they are not sure about if they can do home hemo or not, we take them to the home room and we dialyze them for 5 days, and we tell them just feel how you feel like it. At the end of the 5 day, most of them they end up doing home hemodialysis. So that's we call it Experience the Difference. All patients with home hemo, when you finish the training, very important. Never send the patient for prescription of 3 days, three times a week, because you want them to be more comfortable doing it. So we send them with 5-6 days a week prescription for 2 or 3 months, just for them to feel comfortable. So that will help you to retain patients, and they will feel comfortable with cannulation and things. The different home hemo prescription tailored to the need and the lifestyle of the patient. So you can't have the same prescription for all patients. The patients are different, their lifestyle is different, so you have to be open to that. So offer the patient the option to come to home hemo unit for dialysis when needed if there is sign of burnout or if the partner is not available. Try to keep them in the home room if possible, not with in-center patients, and keep them just for a week or two. And in this way, they will go back to home hemo. We prefer to use AV fistula, but okay to use a tunnel catheter for short daily or longer treatments, such as nocturnal. Do not use AV graft for nocturnal hemo. You can use only fistula, and so if you have graft, you can do only short daily. You can't do nocturnal. You need to teach appropriate surveillance to patients, informing them of sign of sepsis, so that if they have any sign, they immediately notify staff. If there is any sense of granulated tissue, redness at the buttonhole site, you need to stop using it and create a new one. The staff must inspect the vascular access site at least monthly. If patient cannot come into the clinic monthly, use technology. Ask them to take a picture and send it to you. We have a group meeting with the staff member to review safe, proper technique and infection control, such as not opening the syringe, needle, and leaving them around, or having animal in the room when cannulating. Certify the patient or partner after they complete 6-week training. It will give them sense of accomplishment, control, and you're reducing the risk of helplessness syndrome that you see in end-stage renal disease patients. This is a picture of buttonhole on one of my patients. So you can see the arterial side. There is no granulation tissue, no redness, and this is the venous side. So this one of my patients, he's here present with us. His name is James Parker. So he's doing nocturnal, and you can see. So just want to show you the sensor. This sensor that we use. So one in the arterial needle, one in the venous needle. In case there is leakage, if there is leakage by 0.5 cc or sometimes less, the patient is going to hear loud sound and will wake him up at night. So all nocturnal patients, they should have this system, and you can get it. We'll give you more information how to get it. So and this is stockinette, the cover and protect, so that just to keep the system in place. There's just few things that help you. And this is one of patient in vacation and having good time and doing next stage using bag, not PureFlow. Thank you.
Thank you very much, Dr. Daoui. I know that was a lot of information you had to get through, but I appreciate you getting through that in a timely fashion. And I do want to thank you and your team, and remind everybody out there, the participants, to please submit their questions via chat. Dr. Daoui and his team, and as he mentioned, he has a home hemo patient with him to answer any questions that anybody has. They can also submit via the chat. Mr. Parker is there. He was willing to come in to participate in this call so that, hopefully they'll have some questions. I just want to go back again and just say, what does this call mean for you? Again, we're here to promote some best practices. Dr. Daoui shared a lot of things that went on with his program to make it successful. We really want you to take one idea from today's LAN call that you can commit to implementing in your facility within, the next week or month, not 6 months down the road, but what is it you can do that you can take away from this call today that would really be beneficial, that would help, that you could go back and help promote the home hemodialysis. You can send your responses via the chat box, and I will be monitoring that. And any other questions that you would like to submit, please do. And we do have some questions that I'm going to now put out to Dr. Daoui and his team, and hopefully Mr. Parker too. And one comes in from Carmen. She says she's not sure exactly about the statistics, but on the study on recovery time, why the number of patients is different. 500 home hemo compared to 5,000 in-center hemo. Dr. Daoui, can you answer that?
Okay. So the answer is that when we did the study, we did not have. It's very difficult to recruit next stage patient. So it's not easy to get 500 patients. So for us to get 500 next stage patients, that took us a long time and call them in different centers. So we were not able. You can't get that. You can get a lot of next stage patients who are willing to do this type of study. So the requirements on the the requirement in that type study is you need to have at least 400 next stage patient in order for the data to be valid and in order for you to compare with the 5,000 end-stage renal disease patient. So there is not enough patient that time to recruit more.
Okay, thank you. We do have another question that asks, how do patients find your unit?
Good. Well, we have a lot of patients that have found us through the internet. A lot of it word of mouth from other patients, and our doctors believe in it. So a lot of our recruiting comes from our own doctors with new patients coming in. But we do have a lot of outside people that have found us through the internet.
Yeah, we have patients from Boston, from Vermont. We are in the state of New York, upstate New York. So I know myself, my partner, we have patients in different states, and so it's easy to find us.
Okay, great, thank you. A question here from Dorothy. Did the patient start in center, and if so, what was the trigger that made him want to try home HD? I believe that's referring to Mr. Parker there.
When Dr. Daoui told me that my kidneys had failed, the only thing that came that was continually through my mind was that my life was over. I lost control of things. I was going to have to give up my business. I was going to have to stop working. I was going to have to spend my life being controlled by somebody else. Home hemodialysis gave me back my control. It took away all the fears that I had. I now have been on home hemo for quite some time, number of years. I continue to work. I feel great. I can continue to change my schedule based on what's going on with my life. I travel with the machine. In fact, not too long after I was diagnosed, I bought a travel trailer and had the travel trailer modified so that it would take the next stage machine. So now I can go anywhere my travel trailer goes. The motivation for me was to get control back to my life. I have been in stage for a month when I had another medical problem, and I was right, because when I was going in stage, my entire life was around going to the center. I wasn't an hour away, I was 2 hours away. So I was 4 hours getting back and forth to the center. I got great treatment in center, but even though I got great treatment by great people, I felt like crap. And the reason I felt like crap is I was always recovering from the treatment. Hope that answers it for you.
Thank you. Yes, thank you for sharing that. That's very nice. Another question come in. Most of my HD patients are elderly with multiple comorbids. We have difficulty finding patients who are physically well enough to be on HHD. Any suggestions?
Okay. If you review the slide, the benefit of home hemodialysis is for any patient, but mostly for the sickest patient. So if there is certain program, they think that we are taking only the easy patient, but that's not the correct way. If the sickest patient are the one who are going to die quickly, the sickest patient are the one who are going to see significant improvement. So you are not going to choose the best patient, the most stable. That's not the way to do it. You have to change the thinking. If you want to improve the life of your patient, remember the mortality rate, remember the survival rate, and we never say no. And you have to be open taking a sick patient. These are the most challenging, the most rewarding, and you can see significant change, significant improvement.
Okay, thank you. Here's another question from Maddie. She asks, who pays for the service?
The insurance companies.
Medicare, the patient's insurance. There's no charge to the patients other than what their insurance is paying.
Okay, great. Thank you. Susan says, kind of a comment and a question, would love to share the Freedom Study with our facilities. How can we access it?
Yeah, online.
You can access it online, called Freedom Study, or I can find I can send you a copy or send it to Stephanie, and Stephanie forward it to you. But it's online. You can find it online.
Okay, great. Thank you. And that would be nice if you send it to me, and I'd have it too to share with everybody. Okay, we have another question. We have a couple good questions. From Beth, she asks, does this modality help with patients who struggle with low blood pressure instead of high?
So the patient who struggle with the blood pressure, if you see the data when you compare nocturnal and the short daily and the in-center, so the nocturnal, this patient, you can see significant improvement in people with hypotension, and level 3 that you become very symptomatic, you have to give them normal saline. So 67% reduction of intradialytic hypotension if you do nocturnal. So if your patient is having very low blood pressure, you do nocturnal. When you do nocturnal, you can use blood flow rate of 200, 250, compared to short daily when you use 400 or 350. So I think it's possible you can do it, and also you need to give them maybe midodrine before they start treatment, but the nocturnal will be good for them. If not, you can do short daily, and you may keep them stable during treatment. If every day you remove the same amount of fluid, there is no peak and valley in changing the amount of fluid you are removing, and so that's what. Good.
Okay, great, thank you. Another question from Samuel. What psychosocial criteria should be assessed for potential home candidates?
Well, our social workers meet with the patient, and they need to have a safe home setting. We do look when the team goes in. Our tech team goes in and does an initial home visit. They're looking for a safe egress in and out, trying to make sure, like, in case of a situation happening, we need to make sure we could get EMTs in there with a stretcher if we need to. So there has to be, a safe access in and out of the house. Basically, really, we don't really get judgy about people's houses because everybody lives differently. So if the home is, safe and they have electricity, and I'm going to let you take this, Posh, the tech part of it. What you're looking for?
For most of our patients, because NextStage gives you both options of using a PureFlow and bags, we do look at patients' tap water to make sure that it's safe and within drinking water standards before we allow them to use the PureFlow, but it doesn't remove the patients from having the ability to do home hemo. As long as they have an outlet that's grounded in their home for safe electricity, that's really about it. We make sure that they have a smoke detector nearby that's functioning in the house as well.
Okay. Perfect. Thank you. Good. Thank you. There's a question from Kelly for the patient. Mr. Parker, what safety concerns does the patient have? And is the patient ever worried about experiencing low blood pressure, bleeding, etc. while dialyzing?
I think after 4 years, I've pretty much been in all the deep weeds you could find, and I've had all those. And no, I don't worry about those. I don't worry about those because I got absolutely excellent training. I have a checklist, and when I get myself in the deep weeds, I find out that I got cocky and I wasn't following the checklist. And if I go back to the checklist, I get myself out of the deep weeds. And beyond that, I can pick up the phone and get help from the DCI Reuben dialysis nurses at any time I want, 24 hours a day. So no, I'm not concerned.
Okay, great. Thank you. We have a lot of questions coming in. Appreciate all the good questions coming in from the participants. One from Carmen. why the contradiction to use a graft on nocturnal treatment?
Our patients who do nocturnal use buttonholes, and grafts. With an AV graft, you can't use a buttonhole unless you have specific clearance by a surgeon, which in our area is not very often. So that's why we, respect the graft. And if they're going to use a graft on home hemodialysis, they have to stay awake and do it with sharp needles.
Thank you. Good. That's very good. Thank you for clarifying that. Let's see. Shelley asks, do you think that a non-compliant patient is a good candidate for HHD?
I think it's the best candidate for HHD because most of the time they're non-compliant because they don't have control. And we found really once they gain some control, they really do, they take care of themselves.
And remember, it's not only non-compliance because the patient doesn't want to come to the center. It's not easy to come to the center. And remember, depression rate and the symptoms that they experience. So if you offer them something else different, and you like the experience difference, take them to do experience difference with them. Dialyze them more with the next stage machine, 4 days a week, and you are going to see this patient, they will become compliant. So we have just to go, behind the curtain and understand why this patient is not compliant, because he's not feeling well.
Thank you. I got another question for Mr. Parker from Karen. Mr. Parker, did you start using Experience the Difference? And how long did it take for you to feel better? How long have you been doing this modality now? Actually, that was 3 questions.
I can remember that I waited as long as I possibly could to go on dialysis. When I went on dialysis, I eventually went on dialysis. I couldn't walk more than 100 feet without sitting down and getting my breath back, and I wasn't sharp at all. I was like in a fog. And I don't remember exactly how long it took me, but I remember it was certainly less than a month before I was feeling great and getting back to myself. And I forget the rest of the questions, I hope, right?
I'm not sure if this is something that the facility does, but did you start using, they call this Experience the Difference. Did you do kind of like a trial
yes,
home
exactly
hemo where you were still doing in-center?
Yes, that's exactly what happened.
Okay.
I had one treatment in center, and then I immediately went into home hemo and started getting trained. I was capable of doing home hemo fairly quickly as far as doing the procedure. My fistula wasn't allowing me to go on to doing it at home myself. One other thing that I wanted to mention was back to payment. I remember this was when I went on dialysis, I called my insurance carrier. My insurance carrier told me I'd have a $30 copay every time I went in center for treatment. Whereas I qualified for Medicare even though I wasn't old enough at the time, close, but not old enough. And Medicare has been picking up the cost of the whole thing. So it was a huge financial incentive for me to go home hemo as well. I don't know if that's still the case, but I can tell you if I had gone in center for any length of time, I'd be broke. I'm probably broke anyways, but.
And just one more part of that, the third part to that question again, if you could tell the participants again, how long have you been doing this modality now?
I'm pushing 4 years now.
Great, thank you. Thank you. We've got a couple more questions. We do have time, so let's just try to get through as many as we can. We have one more question that says, do all of your HHD patients have partners, or do you have any dialyzed solo?
No, not all of our patients don't all have partners. 90% of them do, but we do have a handful who don't. And they dialyze during the day while they're awake, and we keep an eye on them
Yeah.
So they dialyze during the day. The people who are doing daytime, they do it at night. If they do nocturnal, we have certain program that's specific only for DCI. We can monitor the patient live during their treatment, monitor their treatment. So I didn't talk about this during the presentation because it's just specific to our center, unique system that we have. So you can. But if the patient has no partner, we want them to do it in daytime, but they communicate with the renal center during their treatment. So there is a constant communication. So we never say no, but we need to make sure that it's safe and you know, so, but we do it.
Right. Thank you. Thank you, Doctor. Here's a good question, too, from George Ann. How do you approach the burnout factor with the home patients doing 5 treatments a week?
That's in training. I think that we ran across that quite a few years ago, and we've changed our style of training that even though everybody comes with a partner and a spouse, you primarily direct all the training and the responsibility to the patient, and then the partner's just there to assist. Whereas before, you would get partners that would not want to, but assume the role of caretaker. And we kind of steer away from that. Now we'll bring the patient in for like 2 weeks and we'll train them primarily, and then we'll bring the partner in so that at that point in time the patient is self-sufficient.
Great, thank you. Amy asks, do you find having current HHD patients talk with in-center patients to share their experience is more effective at getting patients to switch modalities?
Have you seen that? You've seen that.
We sometimes will have a patient in the lobby. We don't let the patients in. The patients don't come into the regular dialysis unit, but we do a lobby day, and we've had patients come in and talk at that, and that does go over as helping get people interested.
Great. Irene asks, what is the average patient age group for your home hemo patients?
We go from 20 to 90. It's true. We've had some very young ones, and we've had some very old ones, and a lot of in between.
Okay, great. I have a question. So the patient becomes comfortable with self-cannulation via buttonhole. Have you had any problems with that?
What kind of problems?
Doesn't say.
Well, we have had infections to buttonholes. Patients have, they've alerted us to them, or they caught it early enough. We would stop using the buttonhole. We would rotate sites, treat them do their blood cultures, and treat them with for their infection. But
the rate of infection between buttonhole and in-center using sharp, we didn't see a difference in our with our experience. We didn't see any difference. We have protocol that rigorous protocol that we follow. We train the patient how to, for example, if they see some redness or granulation tissue on the buttonhole, even without pain, without any discharge, we change the site. We tell them by themselves. They take sharp needle and they create a new buttonhole. Then we see them once a month, and sometimes we see them twice a month because they see my nurse one time, and they see me in the clinic with my nurse. And if there is any risk of infection, we can get their picture through. They take picture of the site and send it to us. For bleeding, if they bleed, they know how to stop the bleeding. We didn't see a lot of problem, just routine things that the patient is in charge. So they know, they're educated, and they know how to act on the problem.
Thank you. I think I got time for like one or two more questions. One is for Mr. Parker from Sheila. How can in-center staff better encourage patients to consider home dialysis?
Talk about it. Advocate for it. I am literally amazed at the people that I run across that have no idea that even home hemodialysis exists. It's just an awareness, because once you're aware that it exists, you gotta at least consider it. It opens up so many opportunities.
Good, thank you. I have another question. I think I'll do that. That'd be the last one. Let me ask one more question here from Peggy. I think again for the patient. What is the best thing a home program can do to show support of the patient?
Good question.
One more time. Can you read the question?
Oh, sure. What is the best thing a home program can do to show support of the patient? And that could be for anybody. It does ask for the patient's response, but...
Should go to the patient.
Thanks, guys.
I've always been there for you.
Maybe that's it. I have no doubt that they're always there for me, and they have my best interest in mind, and there's a whole team that supports me, and I feel like they care.
Perfect. Well, thank you. And I just want to thank all of you, Dr. Daoui, your team, Mr. Parker, for taking time out of your busy schedule to talk to us all. We had a lot of good questions. I wish we could get through all of them. We did not, but we tried to get the highlight ones and the ones that I thought were very important. They were all important. And I just, again, stress to everybody, all the facilities out there, just think about your patient population, think about who can do home. You've heard, I think, from the team that, you should never rule out anybody. Everybody is a potential candidate, and really look into who could be home. And I really, again, thank everybody. If you do have any promising practices that you want to share with us in the future for future calls like this, we really like to hear from you. We really want to hear experiences and how your facilities have, how they've been able to increase your home referrals and patients going to home. We'd really like to hear from you for future LAN calls. The next LAN call will be in March for the home. You also follow the NCC on social media for any updates. You can Facebook, Twitter, or YouTube. And again, just thanking everybody for their participation today, and hope that we're closing out. And thank you so much, Dr. Dowie's team and Mr. Parker, again, for joining us today.
Thank you.
Thank you. Thank you. Goodbye.
Bye. Goodbye.